So we're going to be speaking with Dr. Villare today. Dr. Anthony Villare is an orthopedic surgeon with us here at Upland Hills Health. He has been conducting joint replacement surgeries for more than 25 years and is board certified in orthopedic surgery. So Dr. Villare, thanks for joining us. We're happy to have you.
Yeah, hi, thanks for having me.
Yeah, so we talked a little bit about the technology that we are going to be talking in depth about today. Before we went live here, you and I were kind of talking. So before we dive into the awesome technology that I see sitting behind you, I do want to hear from you. What is a joint replacement? For our viewers out there who don't maybe have a good understanding of a joint replacement, can you explain what that is and how it's done?
Sure. Joint replacement, we do that surgery because people get arthritis that wears out their joints. We all know the word arthritis. I think some people don't understand what that word really means. And our joints are just like anything. Pretend your body is a car and the tread wears out on your tire. We have cartilage on the end of our bones, and that's what makes up our joints. Now, what holds together those joints, ligaments, soft tissue, muscle, tendons, they all start to wear out. The cartilage wears out, that starts to make makes the joint weak, painful, swollen. And these are all responses that your body has trying to make it better and actually less painful, but our bodies haven't figured out that it actually makes things worse and more symptomatic for us. So those are the symptoms that we start to get. And when it reaches a point, and usually it's later in our lives, our cartilage has worn away enough, the bone around it has sort of misshapen and gotten worn down enough that the joint can't function as a normal joint anymore. So then you get stiffness, then you get pain, and it all just snowballs downhill after that. So when it reaches a critical point where patients realize, you know what, I'm not doing those little things I used to like doing all the time. I can't do them. My daily activities, my quality of life has just been so confined and limited because of the arthritis in my joints. And we're talking hips and knees mostly today. They decide, well, they find out we have the technology nowadays to change that. And the way we do it is with surgery. Nobody's found any other way yet. We have to do surgery. We have to expose the joint. We have to look right at it. And what we do is under very controlled circumstances, we remove enough bone, just skim cuts, just the surface of the bone. We just remove all that arthritic bone, all that bad cartilage. We get down to fresh bone. And then when we're there, we cap that off with metal and plastic. And then that becomes the new joint, the new bearing, the new ball joint. And then we put it all back together. And then that becomes the patient's new functional, shiny joint. Yeah, and that's the surgery. But then comes the task of rehab after that.
Sure. So essentially you're taking out the old arthritic joint that's no longer working properly for a patient, and they're probably experiencing pain or they're not able to do the things that they love in life, and you're putting in a new joint, a metal joint?
Metal joint, it's an alloy. It's not like it's stainless steel or anything. It's usually a cobalt chrome alloy on one side and titanium on the other, and then there's plastic in the middle. And we're not talking your dinner fork plastic kind of stuff. I mean, the metallurgy in this. I always think to myself, if we put the same kind of components in now that we put in 25 years ago, it would almost be, I don't want to say crazy, but we wouldn't do that because the metallurgy, the technology has improved so much. The density of the plastic to make these joints last longer has just gone forward so much, and it's continuing to go forward. It never ends. The improvements that are being made in trying to make a perfect joint for that patient.
Right. Yeah. I mean, that's kind of the beauty of healthcare, right? Is we're always changing and adapting and finding better ways. And speaking of adapting and finding better ways, I'd love to hear about the Mako robotic arm assisted technology that we have just recently implemented at Upland Hills Health. Can you tell me about that?
Yeah, well, I was excited about that. When I came to join the hospital in their orthopedic department, I had mentioned it to them, and they were very receptive to it, to seeing what can they do, because they want to do, we just talked about this new operating room that we have, new addition onto the hospital, new technology in this room, and what better way to complement it than with one of the newest technologies and joint replacements that you can get. So they were open and receptive to my discussion with them about the Mako system. They acquired it, and we've been using it now for the last, oh gosh, what is it? June, July, last 3 months or so. So, and it's just been fabulous. It's been great to use. The patients love it. And as a surgeon, I love it because it helps me make a better joint for that patient.
Sure. So, you know, as somebody who doesn't work in surgery myself, when I hear the terms Mako robot or robotic assisted arm,
it's hard not to call it a robot, right?
Exactly. Yeah. So is it doing the surgery for you, or are you working with the equipment?
It's not doing the surgery for me, but it's helping me make the better cuts we need to make. Remember I said we removed that arthritic bone. Now, in the old days, let's say, the old days, like, you know, a year ago, we would have special cutting instruments that we would fix to the side of the bone, and then we would make the cuts with the saw blade, just like you see in any kind of workshop. Now, I mean, I say that, I mean, we have obviously surgical instruments, but it's a familiar looking saw and a blade, just like you see. But now, through many studies have been done, and also through the papers related to this robotic arm technology, we found that the cuts that we made weren't as good as we thought we were making them. We thought we were doing a pretty good job, but now it's like when you get the robotic arm in there, and it's not just the arm, there's a whole computer brain behind it. Because what we do, and if you don't mind me going back and talking about this, is I see you in the office, you want a total joint, okay? You're sick and tired of the arthritis you've got and what it's doing to your life. So you come in, we talk about it, we look at your x-rays, you've got arthritis. So then we get a CAT scan or a CT scan of the knee, and that's really just sort of a computerized x-ray slice, but it's taken from the front to back, top to bottom, left to right. I mean, we get a whole big view of that joint, whether it's your hip or your knee. So we get a CT scan of that. That goes into a computer, and the computer then digests that information, and then Stryker is able to compare that to a normal knee, and then from that information, they can figure out, okay, what size knee components or hip components are needed, what orientation, what size. If it's a hip, you know, it's a ball and socket. So how's that socket going to fit? You know, so we can have it right and your hip doesn't dislocate. So all that gets put into the computer before you even get to the operating room.
Okay.
And once we're in the operating room and we're ready to, you know, remove all that excess arthritic bone, that robotic arm is what I use instead of those cutting jigs. And that robotic arm will not let me, which is really kind of a weird concept for someone like me who's been doing this for decades, it won't let me make a bad cut. Because in that robotic arm brain is the CAT scan of that person's knee. It knows where that knee is in space. You can see, oops.
Yep.
You can see, can you still see me?
Yep, we can.
Okay, it just got logged out of the screen here. Can you still see me?
Yep, I can see you. We can still see you just fine. You just might have lost your own video component, but you keep going because we still have your video and we can hear you and see you really well.
Okay, so I can't see you, so I'm just going to describe.
Okay.
Above that monitor behind me are the camera eyes of the Mako robotic arm. It's going to see where that leg and hip is in space. It knows where it is. So even if we were to move the leg left and right, the robotic arm with the blade would move left and right in synchronous, in parallel to how we're moving the leg. So we can't make a bad cut. The blade will shut off, or the arm would not let me push the blade beyond where it should go. So it's almost like I can't do anything but make a perfect cut.
Sure. I have a couple of thoughts. So when you talked about the CT scan, so really what we're doing is creating a customized knee or hip joint for these patients, because we're looking at their specific arthritic issues and making some really well-informed decisions about the surgery and what they.
Well, not to get in the weeds of all this, but you do need, it all starts with having anatomically contoured and normal anatomic bone. I mean, if you don't have that, your joint is not going to function right. So it starts with that, but it's also an important thing, and it's something that I guess maybe we don't really talk about with patients or show them when we show them a model in the office. It's also about balancing. And by that, I mean, when we grab onto that leg and we stress that knee, we don't want it to be loose side to side or front to back. We want it to be nice and snug and solid when the knee is straight and when it's bent. And the same thing with the hip. We don't want to have to move the leg around and have the hip dislocate, or pull on the leg and have it pull apart. You know, we want to be able to fit the joint that is absolutely perfect for that patient and a snug fit. And that's part where the robotic arm comes in, and the technology that we use is to get the right size. To say it's a custom knee is a little bit of a stretch, I would say. I'd love to call it that. But these are components that are there in the room, and they come in different sizes. The difference is we know exactly what size we're going to need when we get in there. Whereas before we did this, before the Mako technology, we had an idea of the size, the component that would fit the bone. And then once we made our cut, then we double checked it and we made sure. Then after we removed all the bone and made the cuts and had the trial components in there, then we would decide, okay, how do we go about getting that snug fit, the balanced knee, as we call it. So it's not too loose, not too tight, it's just right. And now we've done all that practically before we removed any bone in the patient. We still make the exposure in the knee, but with the exposure, like I said, we have to see the knee joint, but we don't want to have to release any soft tissue that's not necessary. Ligaments, capsule, tendons, we'd like to release as little as possible. Well, in the old days, sometimes we had to go back and forth and release soft tissue in order to get that balanced knee joint. Now, we can do that before we've removed any bone from that patient's knee.
Sure. So you're almost kind of doing the surgery twice in a way. I mean, you're doing it.
Well, the way I describe it to patients is, like, usually if the patients are waking up, because sometimes they're given some sedation when we get them into the room, I will point to that monitor and I will say, see, there's your knee. I already know what it's going to look like. I just have to put it in your knee now.
Yeah, that's really comforting. As you know, as a patient myself, I would love to know that. I would love to know, or I do love to know, that you're making those decisions ahead of time based on what my knee or my hip looks like. I think that's really pretty cool.
I think it's exciting. It's such an exciting thing as a surgeon, to be able to show a patient. And hips are even more exciting because we have virtual x-rays that we can bring up. And I could show them a virtual x-ray of the hip joint even before we've done the surgery. And what even still is, I don't want to say freaks me out, but it kind of excites me, is when you look at that virtual x-ray and then after the surgery, you look at the x-ray, the real x-ray, they look identical.
Yeah.
And it's exciting on so many different levels.
Yes. Yeah, it is. We do have one question that's come through that I want to ask you here quickly from a viewer. So the thought of this type of surgery is really scary to me, but the pain I have is getting unbearable. This viewer is 60, and so they're wondering, how long will this new joint last, and should they wait until they're older?
Well, there's several ways to approach it, and I think it's really the way the patient wants to. First off, the components we put in are designed to last 15, 20 years. And with, like I was talking about earlier, the technology of making denser plastic and harder metal, I mean, we're pushing those dates out even more, 20, 25 years. And some of it depends on what you do with it, how the patient treats that hip. Are they hikers and walkers? Do they do high demand jobs? I mean, all those things are going to wear out a joint a little faster. I always tell a patient, if you do heavy labor work after a joint replacement, I can't recommend that you go back to that heavy labor job again, because we want your joint to last. And not to get off on this, but the one thing, and this is kind of important, we're doing joint replacements on younger and younger people all the time. It's just the way society is going. You know, we have active people when they're young that are wearing out their joints, and now they're getting arthritis earlier on. So we're replacing joints in younger patients. And when I say young, I'm talking early 50s, sometimes late 40s. It's not the component it's not the components that wear out soon. That patient group, they're the patients that have the highest rate of what we call failures. And by that, we mean the components come loose from the bone. The bone is the weak link. It's not the metal that wears out or the plastic that wears out. They're stressing that joint so much that the bone can't bond in to the metal enough, and it comes loose. And we're talking maybe 3 years after the joint's been replaced. So I always try to stress to them, you know, I don't recommend it. Try to do something. That's hard. It's like somebody telling me, well, you can't be a surgeon anymore. You got to do something else. You know, I mean, it's sort of a shock, you know, when you have to figure out what can I do when I've been doing this for decades.
But you have a lot of services. You offer a lot of services at Upland. So joint replacement might not be the first option for some patients. There's often other things that patients could try beforehand? Yeah,
the joint replacement should be the last option after everything else has been exhausted. I mean, with arthritis, there's limited, but there are options. There's cortisone injections, there's lubricant injections, there's physical therapy, because joints want to get stiff and weak, so we want to keep them limbered up and toned. So there's therapy. Some braces can sometimes help with certain patterns of arthritis. But when all that has been exhausted and the patient realizes, you know what, yeah, that quality of life we talked about is really getting narrowed down, then we talk about the joint replacement. And I get it. Like, I get the idea of people being afraid to have surgery. I've had surgery and I'm afraid to have surgery done, because it's, you know, you're giving up control. And you know, you're hoping everything goes right and everything. But it is, but in my surgeries, I can only tell you my experience, is that my desire to be rid of that problem began to outweigh and surpass my anxiety and fear, apprehension, I guess, of having surgery done.
Yeah. I think sometimes the fear for people maybe isn't necessarily the surgery itself, but what comes after the surgery. So tell me, with Mako, what are some of the benefits that we're seeing our patients have with a Mako surgery?
Well, it's almost like a domino effect of just one better thing after another. Because I had mentioned earlier that we don't have to play around with releasing this side and that side and going back to this side, you know, to get that balance, that snug knee joint or perfect hip joint that we talked about. Because most of that is almost predetermined from the use of the Mako technology, we can You gotta give me that question again.
Yeah, yeah. What are the benefits that our patients are seeing? And actually,
Yeah.
we had a viewer who had a question, I think, who might, I think this will kind of address maybe some of the benefits. So they're wondering how long it takes to recover from
Oh, right.
the surgery.
That's
And
it. I'm sorry. I kind of,
that's okay. I'm sure you had a long day of surgery, so I don't blame you at all.
But because we have to do less soft tissue dissection, that means there's less that has to heal back, less scarring, less healing of capsule joint tissue, ligaments, tendons. So that means you're going to have less postoperative pain, which means it's also going to make it a little easier for you to start moving that joint with physical therapy. And it also means less pain medicine afterwards. I mean, don't get me wrong, it's still painful. We haven't figured out a way to eliminate the pain yet. But compared to the way we did this 5 years ago, 10 years ago, the way we handled postoperative pain has changed. And with this Mako robotic technology, we're able to even, like I said, domino effect, limit that amount of pain that you have afterwards. If you have less pain, you're going to do therapy better. And that means you're going to get better faster. You're going to be discharged from therapy because they're going to say, you're moving your knee, you got good strength, just go ahead and do it. You're good to go. Now we can't quicken the time it takes for the scar tissue to heal. That is always the one limiting factor we have in orthopedics, is you can do all the therapy you want, you can do all the exercises, and you might have all your knee motion back in full strength. You might still have some aching in that knee because the scar tissue takes time to mature and burn out. And we just can't accelerate that factor. But got to be able to get your knee moving and get it strong.
And I'm sure that the achiness definitely doesn't outweigh the pain that people were experiencing with the arthritis. So
Right.
At the end of the day, the joint replacement, when they're at that point, is still absolutely the best option, especially with the Mako technology. Like you said, the precision, the accuracy, the quicker recovery times. Now, I have to admit, you've been teasing me with that machine back there, so I want to see it. How does it work?
Well, here, I can't see the screen, so I'm going to go back here and you tell me if you can still see me, and also let me know if you can hear me, okay?
Sounds good.
Here's a model representation of what your knee joint is going to look like when we use the Mako robot technology. Can you see this okay?
Yep, we can see it, and we can hear you perfect.
Okay, good. So this is exactly what it looks like. We take this information from the CAT scan. The green areas are the components that we are going to put in that knee joint. And before we make any cuts and remove any bone, we can tweak and change these components as we feel we need to. The computer and the Mako robot is going to put it in its place where it should be, but we can always fine tune it. Once all this information gets locked into the computer, and this is here the whole time we're doing the case, we can see this. Once this is all locked into the brain of the Mako, it gets taken over to this arm. These are the arrays, or just one of them. These are the cameras. And from all this, we can see where that leg is in space while we're doing the surgery. And all that information gets sent out to this. Can you see this arm?
Yes.
Okay. This arm is, we attach a saw blade to the end here. And I guide this arm into the joint. Again, looking at that monitor, and it's a different screen at that time. But once we set it, the robotic brain will actually move the arm so it is aligned exactly where I need to make that cut. And I can move it around if I want, but like I said, I can't make a bad cut. If the cut should be made this way, it won't let me make it down or up. It'll make sure I make it across. This thing will not work if it's not in the right position. And this can move all around. This can, if I can get it here, it's kind of tight. I can move this all around here. So there's a lot of points of articulation that we can move to get that perfect cut in that joint. And most of it happens, a lot of the magic happens back here. And then we also have a Mako specialist there. I don't want to talk too loud. But we also have a Mako specialist who is there assisting us with placing the components in the right place, adjusting it where we need to, also handling any issues that come about with the robotic arm, which really is just alignment issues, positioning, but there's somebody always there to make sure, and there's redundancies with the robotic technology so that in the surgery, it goes flawless.
That's wonderful. So you mentioned that you've had this machine, this technology since about June. So how many surgeries have you done with the Mako technology?
We've done a little over a dozen surgeries with this technology. It's the only way I'll do hip and knee surgeries now because it is such a foolproof technology to use it. And I think part of it is because patients want to wait for things to cool off with the whole coronavirus thing.
Mm-hmm.
A lot of patients are in the middle of work. You know, remember, a lot of patients were, a lot of people were furloughed or laid off for their jobs. Now they're getting back to their jobs. So they can't have it right now. They just got back to their job. But they're always looking maybe towards the end of the year, you know, to have it done before the end of the year, around the holidays, et cetera.
Sure, yeah. So I definitely anticipate you will be doing a lot more surgeries with the Mako technology.
I hope so. I know I will. I love using this thing.
Yeah, that's great to hear. It's been so interesting to learn a little bit more about the technology. And if anybody has any questions for you, Dr. Villare, or maybe wants to schedule an appointment, do they need a referral to do that, or can they just call your office?
You know, I think that's a good question. I wish I could answer.
You just get referrals, right? You don't know how that process works, but we could certainly.
Yeah, it's kind of like all background, but I know it all depends on their insurance.
Sure.
Some insurances will let you call us directly and make an appointment to see me, and I say, come on in, we'll get an x-ray and let's talk about what the problem is and how we can help you. Some insurances, and I don't think a lot, but I know there's some insurances where they may need a referral from their primary care doctor to a surgical specialist like me to have it reviewed.
Sure. What I'll drop the office phone number in the chat box. So if anybody has any questions on how to be referred to you, they can call your office, and I'm sure somebody there would be able to help them figure that out. So I'll go ahead and put that in the chat box. Before we finish up, I do want to give our viewers a few minutes to ask any additional questions that they may have. And while we're doing that, while we're pausing for just a minute to get some of those last minute questions, I think it's really important that we take a second to recognize, you mentioned a couple of times, the leadership team and the surgery team and how open everybody was. And I think it's so unique to have a team of professionals and also a hospital board and a foundation board who are so dedicated to providing the best possible experience and services for our community members. I mean, yeah. I think bringing Mako here is just a testament to how fantastic the Upland Hills Health team is and our volunteer board of directors is, and how willing they are to support technology and advancements in healthcare right here in rural Wisconsin in our hospital.
Yeah, I have to commend them, thank them for that. And I think that was also one of the reasons why I decided to come here, was because I got a sense of that from my discussions with them, that they do love the community. They everything that they spoke about when I was interviewing here it always went back to the community. What can we do to help the community? They realize they're an important part of this area, and they want to stay an important part of the area. They don't want to they feel bad, and I do too as a surgeon, wherever I was at, you know, having to refer someone out to somewhere else. You know, patients want to stay here. This is their home. This is where they have their comfort area. And now that we're able to provide that for them, it's just exciting. I'm real happy for that.
Yeah, we are too. We're so excited that you chose us and that you are sharing your expertise with us. So I don't see any additional questions coming in. So just a big thank you to you for joining us today, sharing more with us about the Mako technology.
Sure.
Again, if you guys are viewing this after we've aired, we'd love for you to send any comments that you have for Dr. Villare to info@uplandhillshealth.org. Like I said, I'm going to put that phone number in the chat box, but I'll also list it here. Your office line to your clinic is 608-930-7115. So if you guys want to get an appointment scheduled with Dr. Villare, or maybe just have a question, go ahead and reach out to him, and we'd be happy to take care of any questions that you may have. So Dr. Villare, thank you so much. It was great to speak with you today, and enjoy the rest of your evening.
Yeah, thanks for having me.
Yeah, absolutely. Bye-bye. Thanks, everybody.
Bye.